My name is Mihir Desai. I'm an orthopedic hand and upper extremity surgeon. So I did my medical school training at Georgetown University in Washington, D.C., and I completed my orthopedic surgery residency at Emory University in Atlanta, Georgia. After that, I specialized in hand and upper extremity surgery at Duke University. When I was in residency, I was introduced to Acumed primarily through exposure to the AccuTrack catalog of screws, as well as the AccuLock 2 distal radius plating system. Since my training and residency and as I continued in fellowship, I continued to use those products and have implemented those in my practice currently. So we first started using the AccuTrack screws for scaphoid fixation, and I think most of us would agree that the system is set up for the user experience. It's a very simple, straightforward technique to use these headless compression screws, and they've worked very well for us. The other very impressive attribute of the screws is the fact that we're able to generate a pretty substantial amount of compression when we're stabilizing these fractures. Since then, we've expanded our use of these screws to other indications and have been very excited to use these for the fixation of metacarpal shaft and neck fractures. So the AccuTrack family of screws has provided us with a cannulated screw system that allows us to fix really a spectrum of difficult fractures. The ones that I'm most excited about are periarticular fractures about the elbow, metacarpal fractures, and problem scaphoid fractures. Because of the differences in sizes and screw diameters, we're able to use these across a variety of indications. And really, fractures that used to be very difficult to fix, for example, the capitellum of the distal humerus, are actually a little bit easier now that we've got a cannulated headless compression screw system that generates so much compression. So generating compression across a fracture site is integral to getting a fracture to heal, especially for problem fractures like a scaphoid fracture or metacarpal head fracture, where the blood supply to those fragments may be somewhat tenuous, and you're really relying on the mechanical stability that the implant provides to get these injuries to heal and ultimately lead to a successful outcome for the patient. So I first started using intramedullary screws, or IM fixation, for metacarpal fractures when I had a couple fairly angulated metacarpal neck fractures in very active younger patients. And for those fractures, really the only technique that was available for how distal this fracture was K-wire fixation. Problem with K-wires is that these patients are limited in how quickly we can mobilize them, as well as the subsequent complications of pin site infections. And so we got really excited with the newer technique that had been described to use the intramedullary screws for fixation. So I started using these for metacarpal neck fractures, and with the hopes of really moving away from K-wire fixation for the angulated or rotationally malaligned metacarpal neck fractures. This technique has been very fruitful for those patients because it allows for much earlier range of motion and less post-op immobilization. So the first few cases that I did with this technique, I would really identify metacarpal neck fractures that were angulated or rotationally malaligned clinically. Since then, I've expanded my use of these screws to metacarpal head fractures, which are truly intra-articular, as well as metacarpal shaft fractures. The benefit of the screw for the metacarpal shaft fractures is it allows me to get a fairly rigid implant in place that allows early range of motion, much like a plate and screw construct would, but the associated comorbidities are lessened because we don't have to make a large incision to place the screw, and the secondary complications of hardware removal, extensor tenolysis, are avoided. So the biggest criticism of the intramedullary nailing system is the fact that the metacarpal head needs to be violated to implant the screw. These screws are placed retrograde across the articular surface of the metacarpal head, and critics of this technique cite their concerns about violating that articular cartilage. So I think some surgeons who may be interested in using this technique for their patients use that as their primary deterrent for trying the technique, because it is concerning that we do have to do something that's a little bit different from what we've customarily done for these fractures. The other criticism is that it's a fairly new technique. It's only been done for several years. The outcomes data really doesn't prove a clear winner between IM screws versus plating versus K-wire fixation. So people who have been using K-wires or plate screws for a long time don't really see a need to change their practice if they're having good outcomes with these other techniques. I think in my own practice, I just find that the earlier return of range of motion tends to steer me towards this technique because I think patients are just genuinely a little bit happier in the earlier postoperative period. So when we're doing the IM fixation of the metacarpal, the incision is going to be placed over the MCP, and it's a longitudinal incision that measures, about 5 millimeters or so in length, and it's going to be centered over the metacarpal head. The screw needs to be inserted within the dorsal third of the metacarpal head, and that ensures that you stay out of the articular surface that's critical for flexion, but also allows you to be down the longitudinal axis of the metacarpal. So when we're placing these screws, the ideal starting point would be right about here, and that would allow us to drive the guide wire down the metacarpal shaft and then do all of our instrumentation and screw placement, and that'll ensure that the screw is down the longitudinal axis of the metacarpal shaft, but again, also within that dorsal third where the articular surface is only involved through MCP hyperextension. I think with time, whenever we have a new technique, we're going to generate better outcome data, and as we continue to collect the outcomes, range of motion, postoperative pain, return to work, return to play, once we get those parameters on our patients postoperatively, we'll have a really good idea of how successful this technique is and see how it stacks up to some of the earlier techniques. So we've been collecting outcomes data on our own patients where we've been using this technique, and the biggest limitation that we're running into is that a lot of these patients are doing really well very early on, and we're having a hard time getting them to come back to see us in clinic. So postoperatively, after an IM stabilized metacarpal fracture, we'll usually get patients placed in some sort of postoperative splint for about 5 to 7 days. And within 5 to 7 days, we'll start the patient on an early active motion program with our occupational therapists. Depending on where the fracture is and how stable it is, I may even put these patients in a postoperative orthosis that the occupational therapist will provide for them. My goal when I treat these patients is that once we get to fracture union, which can be as early as 4 to 6 weeks, we can allow them to begin returning to work and play. Ultimately, I think I grade a successful outcome for my patients as the patient being happy, that they have been able to return to work, that they're able to provide for their families. If we're able to achieve those goals after a traumatic injury that we have to operate on, then I think we've had a successful outcome.